In addition to the history of present illness is the review of systems and the medical, family, and social history. The review of systems is probably the most over-documented element in most cardiology notes. When we're billing for the 99214 level of service, which again is going to be our most common one, you can see here that only 2 review of systems elements need to be documented in order to meet or exceed that specific level of service. The recognized organ systems are listed over here on the left-hand side. And when we're documenting review of systems, there's no requirement that you go into any specific level of detail. There's also guidelines that basically say that there's a shortcut for those services that require the highest possible level of service, which are going to be your level 2 and level 3 initial inpatient cares, your level 5 established patient visit, and then your 2 highest levels of new patient visit. In order to get up to those levels of service, the note has to contain either 10 review of systems, or it could document the positive responses that you obtain from the patient, the pertinent negatives, and then specify that all other systems are negative. And that's something I'll show you a little bit more detail here on in just a second. The medical, family, and social history is the last of the components of history, and here you can see that it's important to not say that these elements are non-contributory, and this basically comes from a couple of different Medicare contractors, and also I believe Medicare has addressed that at a national level, where they say a statement that says, for example, that family history is non-contributory indicates that the physician didn't think it was necessary to ask the patient about family history. Therefore, they don't give you credit for asking about family history. And everything in this subjective portion of the guidelines, the history component specifically, they're giving you credit for the extent of interview that you do conduct. So if you say, I did not conduct this portion of the interview, for whatever reason that happens to be, they just do not give you credit for it. So it's important to hit on medical, family, and social history when you're billing for a service that requires that you hit on all 3 of those. And as you can see over here on the right-hand side, that essentially includes your 2 highest levels of initial inpatient care. So one of the areas where it's really important to understand kind of this nuance of the documentation guidelines is that if you're trying to bill for an initial inpatient care service, there's 3 different levels that you could bill at. In order to get up above the lowest possible level and bill one of these 99222 or 99223s, you've got to hit on all 3 elements of medical, family, and social history. If one of those is not documented, or if everything's documented except for the family history, which is documented as being non-contributory, that's going to hold you back to the 3rd column here, which means the highest level of admission you can bill is at 99221. A couple of other points that I want to make before moving on to the next slide here is that in order to get up to that 99221, you also need to be hitting on at least 4 of those recognized HPI elements. And this is one of those things that holds back a lot of initial inpatient care services, because if you don't hit on 4 of those HPI variables, it basically holds you back to the point that you do not support even the lowest level of hospital admission. What Medicare says to do in those scenarios is to bill the service as the appropriate level of subsequent inpatient care with one of these codes, the 99231, 232, or 233, which generally pays around half of the amount of an initial inpatient care service. So make sure you hit on 4 HPI variables and all 3 of the medical, family, and social history if you're going to be billing an initial inpatient care service. The other thing that I didn't mention when we were talking about the HPI is that there is an alternative to documenting 4 HPI variables, and that's the fact that you could document the status of 3 chronic or inactive conditions. Now, I didn't really hit on this when we first mentioned it because it's not that common of a thing for cardiologists to take advantage of. In order to secure credit for documenting the status of 3 chronic or inactive conditions, this needs to be information that you're obtaining fresh since the last patient encounter, and it needs to be documented fresh since the last patient encounter. So in order to avoid the 4-HPI requirement, you would have to elicit an update from the patient regarding at least 3 chronic or inactive conditions they have, documenting down in the assessment and plan what the status of these 3 chronic or inactive conditions are really doesn't count, because that is not history. That's not subjective information. That is specifically the provider's assessment of those chronic or inactive conditions, and it specifies the plan. So you'll get credit for that later, but in order to get credit for documenting the status of 3 chronic or inactive conditions in the history, you need to be obtaining that information fresh and documenting it fresh during that day's visit. It's just not that common for cardiologists to do, because it typically turns that history-taking process into a big session where you're going to be spending an elaborate amount of time with the patient. The all others negative reference that I made just a few minutes ago is straight from the documentation guidelines. The verbiage that they actually use is right here. All other systems are negative. Now, in order to get credit for this, they do say that you have to document a couple of things. You got to document any positive responses that you get from the patient. You have to outline whatever the pertinent negative responses are, and then you have to say that phrase, all other systems are negative. A lot of times we'll see physicians not list out any positive or pertinent negative responses. They'll just say all other systems are negative. That may or may not work in the event of a regulatory audit, so it's a really good habit to get into, just to make sure you comment on cardiovascular and respiratory organ system reviews, whether they're positive or negative. That's going to make it so you kind of satisfy this requirement. The other thing is, a lot of times I'll see physicians using some derivative of this statement, all other systems are negative. The closer you stick to these specific words, the better. I think it's the best practice to actually use verbatim, all other systems are negative, because that really doesn't leave the door open for an auditor to say, well, you know, the phrase that you used in your documentation doesn't really establish that all other systems are negative. An example would be to say, you know, the patient has chest pain, he denies shortness of breath, all other systems are not pertinent, or all other systems are non-contributory, or otherwise negative. You know, it's like statements like that may or may not work. There's really no advantages to avoiding the term all other systems are negative, whereas if you use it, it's just going to be a lock as far as getting credit for that. Previously I mentioned, you know, when we were talking about the HPI, that the HPI is the one element of history that has to be obtained fresh by the provider and documented fresh by the provider every single visit, that the other elements could be documented by someone else, they could be obtained by someone else, and they can also be carried forward from a previous note. So this is kind of the guidelines from the official documentation standards, where they've kind of given us those standards that I made reference to. So first is that they say, you know, a review of systems and a past family social history obtained during an earlier encounter does not need to be re-recorded if there's evidence that the physician reviewed and updated the previous information. They also tell us that this can be done by describing any new review of systems or past family social history, or notating that there has been no change in the information. And this is the quirky part, is they say that you need to document the date and the location of the previously referenced documentation. So you really need to be documenting something like, you know, I reviewed the patient questionnaire from the last visit. According to the patient, nothing has nothing has changed, and that note was from January 15th, and it's located in the patient chart. That's the level of detail that they're looking for. In practical terms, it's a lot easier and a lot more efficient just to obtain and document that information fresh, especially when you keep in mind that for your most common follow-up service, the 99214, you only need to document 2 of the review of systems elements and 1 element of either medical, family, or social history. Medical history you're going to get credit for as soon as you say anything about the patient's previous experiences with illness, operations, treatments, or injuries. So you're going to get credit for medical history. So really all you're doing by referring to old documentation is getting credit for 2 review of systems, which you could also do by saying that the patient denies chest pain and shortness of breath. So referring to old medical records, I think, should be reserved for initial inpatient care would be a great place to use it for, where you have this great big elaborate note that the hospitalist created a couple hours ago. You don't have to redocument, reobtain all that review of systems, medical, family, and social history. You could just say, I reviewed the hospitalist note. According to the patient, it's still up to date and accurate, and that's from today, and it's in the patient's hospital chart. All of a sudden, you get credit for this great big elaborate review of systems and then the medical, family, and social history that another provider obtained and documented. So that's where I think that using this provision, the guidelines, is a lot more beneficial. The official documentation guidelines also tell us that a review of systems and or a past family social history can be recorded by ancillary staff or on a form that's completed by the patient. So this would be a patient questionnaire. In the audit that I recently conducted for Mercer Bucks Cardiology, there were patient questionnaires. I saw a couple of different forms of patient questionnaires, and those certainly add to the level of documentation. However, they were much lengthier than they needed to be, and they didn't pinpoint the specific buzzwords. So if that's a form that is you're comfortable using, it might be beneficial to kind of redesign that, get it down to a 1-page patient questionnaire, and make sure that it hits on all of the applicable buzzwords that we're trying to secure documentation for. In the case where you are unable to obtain history from the patient because of their condition, the documentation guidelines have a provision that allows you to avoid getting penalized for a deficient or undocumented history. What they want you to document is, number 1, establish that you cannot obtain a complete history from the patient, and then number 2, document the reason why you can't obtain a complete history from the patient. So saying something like a full history cannot be obtained because the patient is intubated and sedated works perfectly well. Based on my exposure to discriminatory regulations that are out there, and this is from working with other clients and exposure to physicians, it's best not to use language barrier as a limiting factor. Apparently there's some regulations that say that if you're treating patients who don't speak English, that there's some sort of a requirement for you to facilitate the use of an interpreter. There's all sorts of different telephone support systems and things like that. Whereas if you were to say, I can't obtain a full history because the patient is non-English speaking, and then you bill a higher level of service relying on that higher level of history that these guidelines allow, that could be viewed as discriminating